So as I said, this is the combined CI and reference group meeting for the Sociology of Antibiotics and AMR project. And I'm very glad to see you all here to help me through this. So this is partly a progress update for people to let you all know where we've got to in terms of the data collection and analysis. But I also want to present, we've been working quite hard on the interview material, and I want to present some of those findings and see what you make of them. So you may recall that there are two main components to the empirical part of this study. One is to interview a range of consumer and prescribers in the community about their prescribing experiences. We did a big project looking at what people think antibiotics are and what they think about antimicrobial resistance and the media engagement. This second project is diving in a bit deeper. Thank you. So Arjun has been busily working on these and all the way from West Australia, because he's actually located there at the moment and trying to finish a nursing degree. So despite those sorts of challenges, we've conducted 56 interviews and they're going really well. We've finished the consumer interviews, 30 of those, a good range of people, although we're struggling with men. This is a kind of typical problem with health research and qualitative research. Typical problem is recruiting men. So we've been trying to exclude women from now on from this part of the study to try and build up the kind of male voice. Also, you'll notice that everyone is quite well educated, and this and the femaleness of the sample might be a reflection that we had to go to social media to recruit people. We've gone to Facebook, and that's been really effective. And the examples are here, the ads are here. But I think it might have brought in a more affluent middle class kind of group of participants. So we need to remember that. We've also conducted 20 interviews with general practitioners, and I've done some of those. And they're a nice mixture of practitioners working in inner urban and outer urban, family, sexual health, and in sort of private through to bulk billing environments. So a nice blend of different ways of providing GP services and their narratives about the prescribing and how it goes. Now we're in the final stage of talking to vets, and we're building up that sample. So I hope to aim for, another 14 interviews, particularly with vet prescribers in Melbourne, to try and kind of mirror the GP part of the study. So later on this year, we should have some things to say about the material that's coming out of the consumer and prescriber interviews. So we've also conducted interviews, and we finished this project, part of the project, 51 people recruited from universities, key people from the journals we looked at, from our own networks and the National Centres networks and the Centres to Impact AMR, government, hospitals, the Royal Colleges and professional associations, mostly in Australia, but we have got a sort of handful of interviews from the UK principally. And that's a nice counterbalance to the Australian voice, because there's interesting resonances across the globe, really, in relation to this whole problem of antimicrobial resistance. We've sought to balance this sample in terms of female representation. We've also got a range of people from human, animal, and research and policymaking settings. The thing to bear in mind with this is that people often have, particularly in Australia, have very blended roles. So, for example, a hospital physician might also be a researcher in an epidemiological study around, infectious diseases. Someone advising policy might have a clinical background and be working in a part of the time in their clinic, but also working in an NGO or quasi-governmental role. So it's kind of interesting, you know, I guess we all knew this implicitly, but to actually draw out the kind of multiplicity of speaking positions that the experts actually have is kind of interesting. The kind of political economy of expert knowledge systems and how complex they are is kind of interesting. So we've done a thematic analysis, and that's what I'm going to focus on today with you to kind of analyze these materials. So this is just where we are at the moment in terms of the expert interview analyses. It's a tabulation of the kinds of themes that are emerging, and you will see that there are a mixture of inductive and deductive codes. I'm going to explain a little bit more about that later. But across the top, you can see the kind of major domains in the thematic analysis that are emerging from our material. And underneath those kind of main themes are the nuances and the complications and examples that are kind of emerging in our work. So, you know, we're looking at systems drivers, we're looking at governance. There's quite a lot of talk about surveillance technologies and strategies and gaps. We've also, and we didn't really anticipate this, but it's not surprising at all. There's a lot of discourse about risk, patient risks, the risk of AMR, and responsibility and blame. So using the Mary Douglas ideas about risk and blame and culpability, that's all threaded through these materials. And so we're raising that up as a theme. But you'll see that One Health is empty, because that's what I want to talk about today. So I want to talk a little bit about the policy currents that are in the kind of the genealogy of this concept of One Health, which is so integral to how we think about AMR now. Then I want to look at some of the challenges that are thrown up in the literature, what seem to be the kind of provocations or blind spots or unintended consequences, alongside the benefits of the One Health approach that the literature is pointing to. Then I'll talk a little bit about my analytical approach, and then I'd like to present some of the themes and then reflect on them. I'd like to thank Jane and Davina, who've actually been in a kind of workshop with us to look at some of these interim findings and helping us, you know, notice what's going on in the data. So it's really nice to see you back here. And now you can see what how I've responded to the conversation that we had previously. So, and we have an expert in One Health policy making here. That's Eric. He's published work on this in this domain. So it's nice to have him here. And maybe there are kind of finer points to this picture I'm about to provide. So I suppose we could say that the One Health concept in general can be traced back as a key moment was the signing of the tripartite agreement. So the, you know, agriculture, the, you know, animal health and WHO coming together to establish this notion that infectious diseases, zoonotic diseases, animal diseases that affect food security can't be dealt with by one of these international agencies on their own. They have to kind of form a kind of cross-sector, you know, organ of international states leadership to actually do something about these problems. And I suppose, you know, one, we can think about what happened in infectious diseases to get to this point. And I suppose we'd be thinking about, you know, BSE in the 90s, avian influenza, you know, swine flu, Ebola, etc. All of those things pointing to the complexities across these three sectors. This is often referred to in the literature as a key moment, the tripartite agreement. I think what's noticeable here is to recognize that One Health is not invented for AMR. And I want to think about the implications of that, the kind of the utility of the concept for the specificities of AMR, given that AMR has a pronounced clinical care kind of component and involves antibiotics, not necessarily pathogens. There are some interesting kind of complexities there. But it's not as if there's only one way of doing One Health, so that other kind of currents in the One Health area demonstrate that it's more than just a kind of policy fix, and that there are other players fleshing out and problematizing and extending the idea of what One Health is. And this is where we get into the kind of one world, One Health kind of conceptualization of the field, and specifically thinking about, you know, the ethical consequences of how we live in the world with other species, global citizenship, etc., and so forth. So that's taking some elements of the need to collaborate, but thinking in a more kind of citizenship-like kind of mode about those things. So the Berlin principles, and there are other examples in the field about this that really try to push our thinking in and around what One Health actually represents. So again, I'm interested in what of the kind of One World, One Health rhetoric is kind of being trafficked into how we do One Health policy making. So in this kind of exploration of what One Health is, I think it's important to see that there's an industry emerging around this concept. So there's a gold open access journal, note to all of us who might want to publish something in One Health, that sees its mission, it's a new journal, and it sees its mission as, you know, kind of pushing forward the science of One Health and bringing together a whole range of sciences and kind of practices around intervening in the One Health domain. Note the kind of big long list of the sorts of sciences that contribute here. And I'm thinking, because, you know, one of the kind of things I'm seeking to do is to think about the positioning of the social sciences in One Health. It's interesting to see that I'm looking for social science and I don't see it, and maybe it's in public health. Maybe from the kind of One Health science point of view, public health is where we might see social science occurring, emergency preparedness. So there's something going on about how the social sciences, which are diverse, and how they articulate here. And I just love this example of one of, you know, the many publications they're making. So scientists have been quick to exploit, respond to this kind of One Health framing of their science. So this is just one cheeky example I found. This is, you know, SARS-CoV-2 infection in free-roaming dogs from the Amazonian jungle. So this is how to do research that's kind of about an infectious disease that affects people, involve animals, and look at the environment, this kind of tropical environment under threat. So I think it's kind of interesting to think through how the sciences are engaging with One Health and what it actually means. So then we come to good old Australia and the policy environment that we exist in our efforts to kind of do something about One Health, and how One Health has become a crucial component of the Australian response. In fact, we have the One Health Master Plan, which is the document that's guiding the second iteration of the national strategy. And I'm interested to think about how they define One Health and so on. So just to kind of get this in our heads, we all know this, but just to kind of bring it to the fore as we go through the qualitative materials, that Master Plan defines One Health as a principle of applying a collaborative and coordinated effort across multiple sectors. So remember that term, collaboration, and about working local, national, global, to obtain optimal health for people, animals, and the environment. It's the kind of statement about One Health that you could never argue against. I mean, who doesn't want this? But how to make this ideal, this principle real on the ground is something that I think is still escaping us, and that we need to turn to think more about how to do this work. And not the only reason, but part of the reason, while we're still kind of troubled by how to implement One Health, I think is because of the occlusion of social science perspectives in how to actually enact One Health in the world. So what's the literature saying about One Health? So, excuse me, I'm having trouble with my Mac mouse. So, looking at the literature about One Health in general, so this is not particular to AMR, but the kind of more generic, more infectious diseases, zoonotics-oriented One Health approach, looking to see at some of the things people are saying about that. The kind of strong current of the zoonotics in One Health. So I suppose people are pointing to the prehistory of the One Health idea and seeing it as located in the zoonotic disease control and the kind of evolution of that kind of approach. So it's something important to recognize when we think about AMR. Siloing is a common theme in the literature, and actually people at Melbourne at the Doherty Institute did this research, and their argument is that the siloing that we see in One Health and infectious disease management in zoonotics commences right in professional and science education. So as we're kind of training new scientists and new professionals, that's where we set up the silos. And if we're going to change the siloedness of One Health, the ways in which silos interfere with One Health and collaboration, we need to go back to how we're actually training our students. Numerous studies point towards a kind of lack of social science in One Health, and this is in general, not particular to AMR, although it's true of AMR as well. When you look at these articles that say, oh, how is interdisciplinary activity in One Health constituted? Social science is always the last discipline named, and it's made equivalent to other fairly, unified disciplines. And as Frid Nilsson et al. Explain, social science is not often understood as the handmaid to science, as the experts to go to transmit the knowledge about the One Health problem to the wider community. And obviously this is a kind of narrow kind of perspective on One Health, on social science. Taking this a little bit further, Craddock and Hinchliffe actually argue that one of the reasons that we're running into problems with One Health is that to say that we need to collaborate and then everyone has to engage with One Health across sectors and across nations and so on, actually diffuses responsibility. It's actually a technique of dispersing. If everyone's responsible, then no one is. No one has to make take the first step. They also argue that One Health is very scientized and very sort of science-centric and top-down. It's a fairly ethereal kind of concept. It doesn't spring from communities necessarily, although I want to say something about that a bit later. And Craddock and Hinchliffe make the point that often this idea that One Health is a scientific problem, it's about governance and science. The social sciences are the go-to discipline for educating the world about the need to understand science. We know as social scientists, that's not all that we do, and maybe not be the best thing we can do to contribute to this domain. There are evaluations of One Health interventions starting to emerge in the literature, and De La Salle et al. Have done a review of that, a systematic review. And I won't go into detail about that, you can find it for yourself. But what they show is that most of the interventions that have collected data about what they've done come from low income settings. And lo and behold, effectiveness seems to be linked to favorable social and economic factors. So the degree to which the intervention successfully works with communities and participates with them and engages with them is key. And also the economic fitness, so affordability, achievability, practicality of the intervention is also key. So to my mind, these point to social science dimensions to program implementation that are more than just, science communications. A few more points I want to make about One Health in general from the literature. One of the arguments is that, and this is the kind of critical social science contribution, assuming that social science can actually help with implementation, what do social scientists say about One Health in a more fine-grained way? So this is Hinchliffe again, and he's worrying that One Health as a kind of science model obscures the particularities of social circumstances. It simplifies reality. As he puts it, it has a metaphysics that's comprised of vectors and nodes and reservoirs and objects that kind of make up the One Health system. And the diagram you can see is a good example of that. It kind of represents the key features of what are thought to be the One Health system to kind of explain what's going on. But to Hinchliffe's mind, this doesn't really help us understand what's really going on in particular circumstances. Volz, Hanna, and Zimicki ask, have we really grappled with the relationship between, for example, humans and animals, and for that matter, the environment? Do we really know how they interact with each other? And a point here to make is that these relationships and these objects are not static. So our animals affect us, we affect animals, we work on the environment and vice versa. So the interactive, the mutually affective components of the One Health system is something that we want to grapple with, and it might be something that social science can contribute to. So this would be moving into complexity theory. I mean, obviously One Health offers itself up as an object of complexity theory from the social sciences, but also from other parts of science. So Wolf is making the argument that what social science can do for One Health in general is to give us another way of visioning what the problem is and what the issues are, and also giving us a way into particularity, specific relationships and kinds of relationships and contexts, something Wolf calls affective entanglements. So really, we're not talking about separate objects influencing each other like atoms, but objects that transform as they become in contact with each other. Rock and Degeling, Chris Degeling at Wollongong, interested in bringing the one world, One Health perspective into complexity theory and experimenting with ideas around interspecies citizenship and solidarity, and that the relationships between the elements, the mutually entangled elements of One Health need to be thought through. So to bring that to some kind of point, well, there's a few more things I want to say actually. So Rabonovitz et al., they make the point that when we turn to the AMR One Health, so specific qualities of what One Health looks like in the AMR domain, they say this kind of zoonotic disease thread is sustained in the science and policy making, and that environment and social science are therefore excluded. not intentionally or maliciously, it's just the kind of vision of what One Health is, in its genealogy, in the kind of zoonotics, is kind of coming into how we think about AMR and conceptualize it. Hannah and Bakskov, and Eric is here with us now, so hopefully I don't misrepresent what you actually think. Amongst the many things they say about the difference between UK and Australia's approaches to AMR One Health is that UK seems to be further down the track. And that's because there seems to be more governmental support for One Health approaches. And that might have to do with the slightly more integrated or managed NHS. Australia seems to still be puddling around a little bit in actually, how do we collaborate? How are we going to actually come together? And interestingly enough, this kind of problem emerges quite strongly in the interview material. Another contribution here, and lucky for me, someone's done a policy content analysis of specifically AMR One Health policy. And consistent with the generic literature, they find that human health is at the heart. So everything seems to be justified in AMR One Health in terms of protecting the human species from the incursions that are coming from animals in the environment. And a little bit more than that, the documents tend to lend force to this notion that if the animal sector and the environment sector can only get its act together, we might not be having the problems we have in human health. So a little bit of blame movement happening in the policy. And as other people have said, Kemenshkova et al. Make the argument that the policy framing for AMR One Health empties it of complexity. And if that happens, if we have sort of very kind of generic ideas about what AMR One Health is, that's hard to implement because we don't have, particular specific kind of perspectives happening there. So how to bring that together? I mean, there are other ways we could interpret this field, and I'm still, exploring this literature, so this will shift slightly. But I guess I want to say at this point that, how is there virtue in examining more closely how we have moved One Health into the AMR environment, given that AMR has specific features which echo and are zoonotic, but not altogether. And there are the kind of sectors involved aren't quite the same. And the pharmaceutical product that's at the heart of AMR is different to what's happening in One Health in other domains. And that might also mean that AMR One Health can make a contribution to One Health in particular. How do we think of AMR as a complex, particularized One Health system? How do we move our thinking into a kind of more, the entanglement and mutually affected elements kind of perspectives on AMR? How do we respond to what seems to be the kind of top-down quality to the One Health discourse and the kind of anthropomorphic dominance, the kind of idea that One Health at the end of the day is really about human health? To what extent is that a problem? Collaboration, obviously, One Health seems to always be about this need to collaborate. This is a kind of social practice. How do we investigate that? How do we help people, progress, advance their responses to collaboration? I'm also worried about, and other people have written about this, I know Eric has, I'm worried, troubled, or should I say, I see an opportunity for repositioning social science in the context of AMR One Health to make a more fully fledged and productive contribution. I'm also interested in the kind of One World aspirations that are also part of the currents in the One Health domain. So the holistic species justice, global citizenship dimensions, to what extent are they relevant for thinking about AMR One Health? Are there clues and lessons and possibilities there for us. So now I'm just going to turn to the material that we've collected and, you know, in relation to the kind of lens, the critical lens that I've developed for you. So just to remind you, one of the first research question from the ARC project went like this: how do experts conceptualize the social and economic aspects of antimicrobial use? And given what I've just said, I guess we're starting to wonder, I am starting to wonder, how do diverse experts and kind of fragmentary and changing expert positions, how does that, what ramifications does that have for how people talk about AMR/OH? How do they conceptualize it? How do they define it? And does positionality matter? What are the common enablers and barriers? So what do people say works and what gets in the way? And how can we be more sensitized to those? And therefore, how can we strengthen, modify, extend the AMR One Health approach? So what we've done, principally myself and Allegra, but also with the help of Davina and Jane and Sue, who may not be here today, we've done a content and thematic analysis of the interview transcripts, and we've taken an iterative, inductive coding approach to build theory. So some of the codes that we've got are deductive codes. They spring from the literature. They spring from what we know are problems or things that are important to One Health. But some of them are emerging from how people talk about this One Health application to AMR. I also like to use a kind of Popperian refutational logic. So, you know, we don't just cherry pick data that suits our emerging theory. When we find data that actually contradicts it, we try and incorporate that into our thinking, because often the kind of outliers, the contradictions add considerable nuance and provisionality to how we conceptualize the material. I'm also, like I've just mentioned, looking at the positions people take in terms of their expert position or their scientific or practitioner outlook, and how that might be influencing what they're saying. So in a sense, these stories are discipline stories about AMR One Health, and in kind of generically microbiology, clinical work and policy making. But as I mentioned before, there's no one that we spoke with who has a unified, monolithic expert engagement. There's a great range of blends of all of these kind of skills and positions. We need to bear that in mind as we think about what they've said. So we're framing the One Health themes in terms of how One Health is framed in the interview material, and then how people talk about how to shape One Health. So we're trying to think about the disciplinary discourses and narratives about what One Health actually is, how they define it, what its kind of breadth and scope and nuance actually is, and then positionality. And then we're collecting material and thinking about material that talks about the doing, the implementation of projects that utilize One Health. So there's a kind of, you know, a two-level kind of division in the material. And as you will see, there's a whole range of perspectives that are emerging under these two frames. And I'd like to talk about several of them and present some data, and then make some reflective comments about those. And then hopefully we can have a discussion. So in terms of framing, and this was quite a common response to questions about One Health, this kind of concept that it was endorsed and valuable and lovely. People actually said that, oh, it's a lovely idea, but it's hazy. So this is a microbiologist in the environmental kind of mode. And they said this: One Health, I guess, we have a really poor understanding of the connection between those key pillars, human, environmental, and animal health. We don't have a mechanistic understanding of how they're connected. But we also, to my knowledge at least, don't have a particularly good understanding in terms of what we can do to actually intervene, or alternatively take measures to stop resistance. It's often flung around as a sort of hazy buzzword. And this kind of idea recurred across our interviews. And I suppose, in 2022, in the beginning phases of a national strategy that makes a lot of One Health, we need to, this kind of take on what it means is an important piece of information. People don't really know what to do. There's also a strong theme of the kind of human orientation of One Health. So there are variations on this, but this is an interesting one from an animal health policymaker who says, we often talk about One Health. What we're really talking about is human health, and what we need to do to the environment or to the animal sides of the equation in order to improve human health, without looking at, well, how does that benefit animal health or environmental health? So if you remember that some parts of the literature are reporting that, human health seems to be at the heart of AMR One Health, this seems to be being echoed through and pointing to, we've kind of lost kind of the handle on animal, environment, one world kind of dimensions to One Health. So does that mean that's where AMR One Health goes? Or are we losing some, we're losing One Health as we apply it to the AMR domain? Then there's lots of positionality. There's lots, and I'm calling them gazes. So I'm thinking Foucauldian ideas about ways of knowing the world and how that generates knowledge about it. So the kind of power knowledge perspective. And I want to keep working on this idea of disciplinary gaze, and remember that no one has a unified or sole kind of gaze. People have this kind of multiplicity of gazes. But what was strong in the literature, in the interviews, is that particularly clinicians can't really see why One Health would apply to them. It's almost as if One Health stops at the hospital entrance, the helicopter pads, and inside the hospital, One Health is just not really what's going on. There's something about patient level issues. And this is a physician researcher saying, in the hospitals, we're so focused on these patient level problems. Like sometimes we don't really get the perspectives of One Health, they're saying. And I feel so much of what happens to the patients that we look after, at least particularly like in transplant, it's much more related to interactions with the healthcare system rather than acquiring a drug-resistant infection because of some One Health reason. Some of the people I spoke with actually went so far as to say that One Health did not impinge on their professional practice because they were pretty ensconced in a kind of, inner urban major hospital context. So I think there's something about the clinical gaze, but also about geography and the intensification of health services. Because as you'll see later, some people working in different kinds of healthcare contexts are more open to the relevance and salience and benefits of One Health reasoning in their work. So this is a kind of provocative kind of comment from a microbiologist working in microbiology for human health. and it's kind of strident, maybe overstated, but because it's notable because it's so strong. Maybe it indicates a kind of scientific chauvinism, as if the kind of true biologists, the true microbiologists have got hold of what One Health really is. And they say the concept of One Health is a nonsense because the idea that that's a species tension between humans and the rest of the planet it's just a medical construct, really. If we pretend you're a tree for 5 minutes, you don't actually care about those kinds of concepts. They're silly distinctions that are around policy settings. But in terms of the spread of AMR dynamics, its consequences, it's a nonsense. So for a true microbiologist, One Health is a nonsense. True microbiologists are already there. It's a little short of embarrassing to say to a microbiologist, were you aware that bacteria in animals and plants and humans communicate? It's something that physicians have had to learn. So I think it's a useful term, but I think it reflects that the policymakers are extremely ignorant. So there's something going on here about the purity of some scientific gazes on the problem, and how that science is separate to, pre-exists, that kind of truth pre-exists policy making and the kind of complexities of human health and animal health. I think there's something really significant going on there when we think about collaboration in the One Health domain for AMR specifically. Vets also had, people working in animal health also had things to say about these issues. So this is from an animal health policymaker. And as I said, the people I spoke to who are vet in this domain, sometimes we're still practicing as vets in, clinics in urban environments. So doing a bit of both, advising government, writing policy, but also treating animals. One Health is a concept that's attractive to vets because it makes us feel that we're going to be recognized and have something to contribute. But it has very little traction with my medical practitioner colleagues who tend to believe that they have the full complement of knowledge, and anything outside of their complement of knowledge is less relevant or less valuable. So again, a really important gaze on what's going on. When you think about what physician researchers say about One Health, they're seeing the patient and they're struggling with the bedside care. One Health doesn't really help them do that. But to other people, it looks like physicians don't want to know about One Health. So there's sort of communication issues and representation, professional identity issues articulating through how people think about what's going on in AMR One Health. I think it's really, really interesting material we've got. So let's go to shaping. How are people thinking about what's actually happening? So this is not what they think it is, but this is more about how it's affecting what they do, and particularly around AMR. And as the literature is showing, this is where the action is, how to turn this idea into something beneficial on the ground so that we can actually prevent AMR. So this is another animal health person, but they're also got a background in human health and nursing. It's an interesting kind of transition. So even when you look at the AMR plan for Australia, there's all these great ideas of what to do, but there's nowhere that's saying how it's going to be done or how it's going to be checked or assessed to see that people are competent, or where the funding is coming from, or support that people are going to get. So quite a long list of implementation issues that are coming from the field. Remember, we've done these interviews in the last 12 months, so people know that there's a One Health master plan. And I suppose they're thinking critically about that. Another comment about siloing. And the thing I want to say about siloing, there seems to be common knowledge of that, although not altogether sustained by the ways in which the complexity of professional lives in AMR, but also that internally the disciplines or the sectors are fragmenting and fragmentary. So it's not it's not if the silos are monoliths that don't talk to each other. There's fragmentation within fragmentation. So another animal health person. My experience has been that funding and the perceived threat to certain silos is a bit of an impediment to a One Health approach. Even though the research tells us that a One Health approach is better in terms of cost effectiveness in so many cases. But I guess some people, particularly in remote settings where funding is hard to come by and they're under-resourced at any rate, they are protective of what little funding they get. So there are other examples in the material that are just pointing to austerity, the lack of resources. And remember the kind of review paper said that things are going to be more effective if they're cost effective. So obviously there are issues around doing AMR One Health in a way that doesn't impinge on existing and tightly managed budgets. And to the extent that that doesn't happen, the One Health collaboration, it's in a sense that the funding arrangements for healthcare produce the silos. The silos are defense mechanisms against fragmentation. There's also some talk, and because we did speak to people who are not working in urban areas, that things are different out there in parts of Australia. And there's some talk that maybe One Health has more salience, although I think even in this example, we'd still have to question to what extent this is a fully fledged One Health perspective on how to do AMR prevention. So this is someone working in remote animal health. And that person says, I like to think that I practice in a One Health approach because we work very closely with our health clinics, which are often the people clinics, the human health clinics in our communities. We often work quite closely with the environmental health practitioners, the Indigenous environmental health practitioners that work in those clinics. And often we follow up on things together. So for example, in a few of our communities, sarcoptic mange or scabies is quite prevalent. So what we'll normally do, if we have permission from the family, but the health practitioners can, I guess, pass on the information to me that the people in the house have got issues with sarcoptic mange, which is a zoonotic disease, and we will often go straight to that house and try and treat the animals as well. Is this, this sounds more like One Health or the kind of zoonotic example of One Health, but is it truly a prevention approach? It sounds more like a treatment approach. But anyway, something to think about there. And lastly, people talking about this collaborative dimension. So people were reflexive with the social dimension of One Health and recognize that it's more likely to be workable and pleasant and effective if people focus on the social relationships that make it so, that make collaboration. So this person, also working in veterinary health, says actually going ahead with One Health or people seeing the need for it is built on relationships. You need to trust the person. You need to understand what they do. You need to understand what they're doing professionally. But the other thing that we also found in research that we did as part of it is that you need to have a bit of professional insight and humility. So that kind of, I like that kind of notion. And I think it chimes with the One World, One Health citizenship idea, and that One Health is more than just a technical exercise in sharing data, but it's actually about the kinds of relationships and the kinds of professional relationships that are made possible through the One Health collaboration. So lots of food for thought in that material. I hope you agree. I'm just having a lovely time thinking about it all. So just to reflect on that material and draw out some perspectives. And remember, this is an interim kind of analysis. So with qualitative research, I'm going to be evolving these ideas. So looking across the materials, we can see that the One Health, AMR One Health, is endorsed in principle. People, I mean, how would you argue against it? It's obviously a great idea and people endorse that. But they're very rarely able to speak of it as a practice, except possibly in the rural and remote contexts. I think that's important kind of to recognize what's going on there. There's also a lot of talk, as I've just talked about, this kind of notion of collaboration as a social interaction. It's about shared language, shared problem solving, trust, and this idea of kind of humility in those social relationships. It's kind of an interesting idea. So collaboration is a social practice. And so how do we make that happen? People have to, enable it. It has to be kind of made. The Australian response seems to be fragmented, but as I said, so are the sectors themselves. So everywhere we looked, it's partly a function of the complexity of, the complexity of the sample, but economic conditions of austerity, geographical differences, the difference between remote and rural, combined One Health versus a large urban research hospital, One Health has to articulate across those environments. And then institutional support, the lack thereof, and the lack of resource and guidance for actually how to mount the collaboration seems to be an issue. And I suppose, the material is pointing to the need for a kind of extended model. So some of the literature on One Health in general talks about this extended One Health idea, which is more fully embracing of environmental and social perspectives. How do we take that into AMR? And I know everyone wants it, but how do we actually make it happen so that we can unhook some of the counterproductive effects of One Health, the kind of top-down scientism, the zoonotic bias, but also the human health bias, and thinking about the ethics as the underpinning kind of framework for actually collaborating effectively. And of course, it's my job to say, and I know Eric said this in another context, I think, the status of social science in AMR One Health is important. And I think, really fine-grained descriptions of actually what people are doing would really help, because it would give people conceptual maps of what other people are doing and advance the field, hopefully. And I guess more generally, thinking about these materials and our other work, and thinking about the social science contribution. So thinking about this idea of entanglements and how the elements of the One Health system are affecting each other. It's a dynamic assemblage of microbes and pharmaceuticals and science and society. So thinking more sociologically about about what's happening. And I don't know whether I've got the wrong end of the stick here. It'd be really interesting to see what you say. But it seems to me that, these antimicrobial assemblages have been organized in such a way to address health, that those same assemblages are the ones that make AMR. So our problem essentially is, what do we do when we have a much needed solution for threat to life? Antibiotics save lives, but the use of that technology is the problem. So I don't think we're very good in late modernity, in our governmental and scientific systems, of thinking about the kind of, the Janus technology, something that's both a solution and a problem at the same time. We like to disaggregate solutions and problems and use solutions to attack problems. Well, what happens when they're the same object? And that's the struggle we're in, I think. And then just more generally, I think, what's occurring in these materials from these practitioners, and having worked in the field now for some years and thinking about pandemics more generally, we've been through a period of hyper neoliberal governance of social systems, with the kind of investment in austerity, the kind of disinvestment of government from society, and a kind of, the basic conservative ethos of status quo politics. I don't know that political system has done us any favors in moving ahead with a problem that's going to require humility and trust and collaboration and some resources and different ways of addressing the problems.